Hello, ladies. What if I told you there is a medication that reduces your risk of heart attack by 25 to 35%, cuts stroke risk by 20%, and costs less than $1 a day? That drug exists. It's been studied in over 170,000 patients across 26 major randomized trials, and yet millions of people who should be on it are not. And millions more stop taking it because of side effects that, in many cases, the drug is not even causing. Today, in part one, we're going to cover how statins actually work, what the evidence shows, which ones are available, and why most cost almost nothing, and a critical pharmacology distinction, hydrophilic versus lipophilic, that most patients have never heard of, but that explains a lot about side effects and timing. Part two will cover LDL targets, combination therapies, and what we call the nocebo effects. So let's go. Let's start with how statins work. To understand statins, you need one piece of biochemistry. Your liver produces cholesterol through a long cascade of enzymatic steps called the mevalonate pathway. The rate limiting step which is the bottleneck that controls the whole process, is an enzyme called HMG-CoA reductase. Statins are competitive inhibitors of this enzyme. So they fit into the active site and they block it. So when you inhibit HMG-CoA reductase, two things happen at the same time. First, your liver produces less cholesterol. And second, the liver upregulates LDL receptors to the surface. These receptors are like fishing nets. They pull LDL particles out of the bloodstream. So you get a double effect. Less cholesterol being made, more LDL being cleared from the circulation. That's the core mechanism. But the mevalonate pathway doesn't only make cholesterol. It also produces compounds called isoprenoids, including CoQ10 and a family of signaling molecules. So when you block the pathway, you reduce all of these downstream products. This is why statins have what we call pleiotropic effects, anti-inflammatory properties, plaque stabilization, endothelial protection, benefits that go beyond what pure LDL reduction does. This also comes up again when we talk about muscle side effects. So, what about potency? Potency varies considerably between the agents. Rosuvastatin and atorvastatin are the high-intensity statins. They can drop LDL by 50% or more. Simvastatin and pravastatin are moderate intensity. The American College of Cardiology and the American Heart Association, ACC-AHA guidelines, classify statins by intensity as high, moderate, and low. And that intensity should be matched to the patient's cardiovascular risk. Now, let's talk about what the evidence actually shows. The Cholesterol Treatment Trialists Collaboration, or CTT, pooled data from over 170,000 patients across 26 major trials. And the headline finding was, for every 1 millimole per liter reduction in LDL, which is roughly 39 milligrams per deciliter, you get approximately a 22% relative reduction in major cardiovascular events. Heart attacks, revascularizations, ischemic strokes, and all-cause mortality goes down by roughly 10% per millimole of LDL reduction. So yes, statins help you live longer. This is not controversial anymore. Secondary prevention. Patients who've already had a heart attack or a stroke shows the largest, most unambiguous benefit. Every major cardiology society in the world recommends high-intensity statin therapy for secondary prevention without exception. Primary prevention is more nuanced because the absolute risk determines the absolute benefit. So if your 10-year cardiovascular risk is 20%, statins make a much bigger dent than if your risk is only 3%. But the evidence supports treatment across elevated risk primary prevention populations. One more mechanism worth mentioning. Statins stabilize atherosclerotic plaques. The dangerous plaques aren't the big calcified ones. They're the soft, lipid-rich, vulnerable plaques that rupture and cause acute heart attacks. Statins make those plaques less likely to rupture, independent of LDL lowering. This is why mortality benefits appear faster in trials than pure plaque regression regression would predict. Now let's talk about the available statins and the cost. So there are 7 statins approved in the United States, and here is where the story becomes remarkable from a public health standpoint, because nearly all of them are now off patent, and most cost between $4 and $20 a month as generics. Atorvastatin went generic in 2011. It had been one of the best-selling drugs in the world. It's known as Lipitor. Now you can get it at most pharmacies for $4 a month. Rosuvastatin, the most powerful statin that we have available, went generic around 2016. The 2 workhorses of cardiovascular prevention are now essentially free. There is genuinely no cost barrier to high-quality statin therapy in the United States today. One practical note on simvastatin: it has significant drug interaction issues at higher doses. Anything that it inhibits, the CYP3A4 enzyme, yeah, it's a mouthful, certain antibiotics, antifungals, some cardiac drugs can raise simvastatin levels dangerously. The FDA restricted simvastatin to 80 milligrams because of myopathy risk. It's still available but used less frequently. Atorvastatin and rosuvastatin are generally preferred for high-intensity therapy. Now let's talk about hydrophilic versus lipophilic. Now here's a pharmacology distinction that most patients have never heard of, but that has real clinical implications. Statins can be divided into 2 chemical families based on their solubility. Lipophilic statins dissolve in fat. Hydrophilic statins prefer water. The lipophilic ones are atorvastatin, simvastatin, lovastatin, and fluvastatin. The hydrophilic ones are rosuvastatin, pravastatin, and pitavastatin. So why does this matter? Lipophilic statins can passively diffuse through any cell membrane, muscle cells, brain cells, wherever. Hydrophilic statins need an active transport to enter the cell. The liver is rich in these transporters that pull the hydrophilic statins in it. Other tissues have far less of this specific transporter, so hydrophilic statins are more liver sensitive. What's the clinical implication? Lipophilic statins penetrate muscle tissue more readily and are more likely to cause myalgias or muscle aches. Hydrophilic statins, particularly rosuvastatin and pravastatin, have a better muscle side effect profile. So if a patient is on atorvastatin and develops muscle symptoms, switching to rosuvastatin or pravastatin is sometimes a simple and effective solution. Now let's talk about half-lives and timing. And here's a question patients ask all the time. Does it matter when I take my statin? The answer is it depends on which statin you're on. Your liver produces the most cholesterol at night. HMG-CoA reductase activity follows a circadian rhythm, and it peaks during the overnight fasting hours. So if you take a short-acting statin in the morning, by 2 a.m. when cholesterol production is ramping up, the drug has largely cleared from your system. You have missed the target window. The short-acting statins, simvastatin, lovastatin, and pravastatin, all have half-lives of 1 to 3 hours. These should be taken in the evening or at bedtime. Studies show clinically meaningful differences in LDL lowering when simvastatin is taken at night versus in the morning. This is a real pharmacological effect. It is not a minor detail. Atorvastatin has a half-life of 14 hours with active metabolites that persist even longer, and rosuvastatin's half-life is approximately 19 hours. Both of these cover the overnight window, regardless of when they are taken. So take them in the morning, evening, whatever works for you. Adherence is the priority. And one more practical point. Lovastatin is the only statin whose absorption significantly increases with food. All others can be taken without a meal, though some patients tolerate them better with a light snack. So to summarize part 1, statins inhibit HMG-CoA reductase, reducing cholesterol synthesis and upregulating LDL receptors. The clinical trial evidence for reducing heart attacks, strokes, and all-cause mortality is among the strongest in all of medicine. Most statins are now generic and cost under $10 a month. Hydrophilic statins, particularly rosuvastatin and pravastatin, are more liver liver selective, and have better muscle side effect profiles. And short-acting statins should be taken at night to match the circadian peak of hepatic cholesterol production. In part 2, we're going to cover statin-associated diabetes, how we set LDL targets based on individual risk, the full toolkit for patients who need more than LDL lowering and can't tolerate statins, and the fascinating science behind why most people who think they can tolerate statins actually can. See you there.